Hi, and welcome to Couch Conversations Beyond the Textbook, where real talk meets real life in the world of mental health. We're your hosts, Abby and Bethany, two therapists who have been through the textbooks and are entering the trenches. This is a space where we unpack what they didn't teach you in grad school, the messy, the meaningful, and the moments that shape us as professionals and people. So grab a seat on the couch and let's dive in. Please note that the content of this podcast is for informational and educational purposes only. It is not intended to be a substitute for professional mental health advice, diagnosis, or treatment. Always seek the guidance of a qualified mental health provider with any questions you may have regarding your mental health or medical condition. The views and opinions expressed by hosts and guests are their own and do not necessarily reflect those of any organizations or professionals they may be affiliated with. If you are in crisis, or if you think you may have a mental health emergency, please call 911 or contact a local mental health crisis line or emergency service in your area. Hi, and welcome back to Couch Conversations Beyond the Textbooks. I'm your co-host, Bethany.
And I'm Abby.
And this is take 3 for us today.
Yeah, technical difficulties. It's been awesome.
That's okay. That's how the day is going. And you know what? What would your therapist say about that?
Well, I'm saying I'm just going to own it and move on.
That's right. How can we accept the things that we cannot control?
That's true. Although I could have controlled my phone dying in the middle of the last episode.
Well, you know what? You could have, but that's okay. I don't fault you for that. I could not control. I could not control your phone dying. So I feel zen about it. And we are just going to move right ahead. Yeah. Because you know what? Just acceptance of life things. Because even though you could control it, it's just, that's life.
I chose
and that's
not
okay.
to.
That's okay. So,
anyway,
Abby, tell people what we are talking about today.
We're talking about diagnosing.
Ooh,
diagnostics. And we are going to, we have our trusty DSM-5-TR.
For those watching on YouTube, this is like the Bible of diagnosing by the American Psychiatric Association.
Yeah.
That clinicians use to diagnose clients.
Yes. Tell me your thoughts and feelings on diagnosing clients.
I have lots of thoughts. Some may be conflicting. Yeah. I think that there's a lot of good that can come from diagnosis. There's a lot of necessary that can come from a lot of necessary. That wasn't even a complete sentence. That's where I'm at now. That can come from diagnosis. But I also think that there's a lot of overdiagnosis. And I believe that as a society, we tend to overpathologize. Big word for me.
Good job.
We tend to overpathologize regular life events. And that's not to take away from the pain and the hurt and all of the things that life throws at people. But I tend to think that a lot of times we will slap a diagnosis on sadness and call it depression, or fear and call it anxiety, or just regular anxiety, because anxiety is a normal human feeling or emotion. And then we say that people have generalized anxiety or whatever it might be. And that's not to say that some people don't have that diagnosis, but I think that sometimes we tend to overdo it. And part of my frustration with that is that in my job, our job, especially at a private practice, we are required to diagnose if we are taking insurance. Insurance requires diagnosis of clients. And I have a bone to pick about that. And I will not get on my soapbox about insurance. But if I could get on a soapbox about it, I would, because I feel very strongly about insurance. But I will not do that for this episode. But just know that that is partially probably a lot of the reason why I think there's a lot of overdiagnosis.
Agreed.
So, hot
And for those
take,
of you,
maybe.
yeah, for those of you listening, Bethany is very close to giving birth.
I am.
And so she is feeling things very deeply right now.
Hopefully by the time this episode comes out, I have given birth.
Yes.
And yeah, maybe I'm just feeling more passionate about it because I'm like all fired up and my mama bear instincts are coming out. But
Maybe. Yeah.
yeah, I don't want to discredit people that do have diagnoses or that have really
Yeah.
been helped by that because, like I said, there's a space for that. And I do
Yeah.
believe that it can
Yeah.
be very
There's
helpful.
definitely a place for diagnosis. And I want to really emphasize how grateful I am for the way society has opened up and normalized mental health care and the that we are going in the right direction in that way. But I too have seen, instances where it has become fad like to have a disorder. Um, we, we hear people say all the time that I I always use the same example. I'm OCD, when really people
Mm-hmm.
just like things to be neat and clean. OCD is a very serious disorder, and
Yeah.
that tends to discredit the seriousness of the disorders. And so there is a place for it for sure. And there are disorders that need diagnosis for improvement and for medication and to see results. And then there are diagnoses that are not super helpful. And
Mm-hmm.
you mentioned depression and anxiety, and those are people tend to feel sad or feel depressed and say that they have depression, and that's not necessarily the case. Where um, to have a diagnosis, you have to meet criteria, and feeling sad for 2 weeks is one of the five criteria you have to meet to have
Mm-hmm.
major depressive disorder. And so it's a very slippery slope. There are good and there is bad, and there is insurance, as you have said, and there's just a lot that goes with diagnosing that, that needs to be looked at and discussed. But when it comes to grad school and learning to diagnose, I remember feeling very, very overwhelmed and feeling like, oh man, diagnosing people is a huge part of therapy and it's something I have to master. And I'm going to be diagnosing every single person that comes into the office. And that was a huge misconception. That is
Mm-hmm.
not at all what this looks like.
Yes, I would say the same. Diagnosing can feel overwhelming. You will not memorize your DSM,
No.
unfortunately. You'll know the basic ones. Um, but a lot of times if there is more of like a niche diagnosis or a client that you're working with that's a little trickier, you'll have to do some research. Um, I would say in the real world after grad school, if you are working private practice, I don't know if community mental health requires a diagnosis. I have not worked in community mental health,
I'm not sure either.
but private practice does if you're taking insurance. And a lot of times, yeah, that can be tricky. I think that it can be hard when there's some diagnosis is not helpful for clients. I don't typically ever tell a client what I'm diagnosing them with, unless they have been previously diagnosed
Mhm.
and they tell me about it, then that's the diagnosis I will go with. If they've been diagnosed by a primary care doctor or a psychiatrist, if they're on medications for a specific diagnosis, that makes my job a little easier. I can usually just go with that. There's been times where I'm like, I don't know if I agree with that diagnosis. And that's
Yeah.
not to say that I'm smarter than a doctorate level clinician, but there's a lot of clients that I've had that are like, oh, I was diagnosed with this at 12 years old
Hmm.
and now I'm 26 or whatever it might be. Now I'm an adult and I'm like, that's, yeah, that's interesting that you would be diagnosed with that at 12 years old. And then you come to find out, oh, actually, you were going through some pretty traumatic stuff at 12 years old on top of this, and
Yeah.
now you've been diagnosed and carried that along with you for your whole
Hmm.
life. And I think that that can be kind of tricky.
Yeah. Yeah. And I think there are some diagnoses that you see as a kid that, you know, you can quote unquote grow out of.
Mm-hmm.
Um, I see that with, ADHD. Sometimes parents or teachers want an answer as to why a kid is having a hard time settling down in class. And um, so sometimes it's just easy to slap a diagnosis on that and say, this child has ADHD. It's gotten easier to get diagnosis, I think. Um, Speaking of to what you were saying, I have had working in college with the college age population, I have had clients who have come in with an ODD diagnosis, which is oppositional defiance disorder, from when they were a child. Um, and then they come in and I'm talking to them, at 20 years old, and I'm not seeing any of that when they very well could have had, you know, an experience or have been more oppositional as a child. ODD is, having a hard time with school and regulating your emotions and being more, hostile and angry and um, defiant and negative towards adults. Um, and there's like with every diagnosis, there's different criteria you have to meet that diagnosis. But you see that more as a child, I think, than as an adult. And as you
Mm-hmm.
grow and mature and learn to regulate your emotions, those diagnoses can and may fall off.
Mm-hmm. And I think that's what's hard about diagnosis is because even with ODD as a child, that is associated with personality disorders as you get
Yeah,
older, specifically antisocial personality disorder,
yeah,
which can be difficult to carry around. And I do not take personality disorders lightly.
right.
A lot of personality disorders these days are thrown around. A lot of traits of personality disorders are put onto people.
Hmm.
Um, and I think I have met quite a few clients who have been diagnosed, in my opinion, these are all my opinions, who have been diagnosed very young with a personality disorder, which I don't think should be allowed because our prefrontal cortex is not fully developed when we are, you know, 13 years old. But that's a whole other tangent.
Hmm.
All that to say, a child being diagnosed with ODD, if they're carrying that around their whole life, there's already a stigma towards antisocial personality disorder and its connection to ODD and how that might manifest into antisocial, when really it might not. But now they've had this diagnosis put on them.
Hmm.
And considering what's the child going through during this time
Right,
that they were diagnosed with this pretty hefty disorder. And I don't even
right.
like the word disorder in general. So, yeah, there's
Yeah,
that. I would say I hold more of a holistic wellness view towards humanity. And I do think that we do overdiagnose. And in the same sense, there is a lot of good that has come from diagnosis. Like,
right.
for example, schizophrenia, learning more about that, medications that can help with that, bipolar disorder, someone that truly
Hmm.
has bipolar disorder, being able to stabilize with medications,
Right.
really important. But you had mentioned OCD being one disorder that you feel like it's thrown around.
Hmm.
I personally think that bipolar disorder is thrown around, not necessarily in the clinical world, but people who don't
Right.
know the DSM, don't know diagnosis, will be like, oh, that person's bipolar because they might have a mood swing.
Hmm.
That's not what bipolar is. So, as a society, we're widely incorrect about what bipolar disorder is,
Yes.
in my opinion,
Yeah.
because it's not just somebody having a mood swing one day. Um, so I get pretty, yeah, I,
Yeah.
and so it's kind of interesting because in the same sense where I'm like, not, I don't love to diagnose all the time. I also get defensive of these diagnoses that we're just throwing around because
Yeah.
to say like Well, and that automatically adds a stigma to these diagnoses saying like, oh, well, they're bipolar because they have mood swings. Like now someone who actually does struggle with bipolar is going to think you think a certain way about
Hmm.
them. And that's not fair because people can function well and have bipolar and they
Yeah.
can be doing everything they can to manage it.
Yes. And um, like you're saying, these these diagnoses and these disorders, they have very real ramifications that come with them, right?
Mm-hmm.
And somebody who, I mean, I know people who have bipolar disorder that you would never ever know. Um, because if you actually have this disorder and you are managing this disorder, you are functioning as if you don't have this disorder, if that makes
Mm-hmm.
sense. And there are very good things that can come from, like you said, schizophrenia. There are very real disorders that need to be medicated and they need to be managed. And then you have disorders like, generalized anxiety disorder and major depressive disorder that are so overused, in my opinion, overused. Working in a school, I saw people wanting diagnosis for everything.
Mm-hmm.
And it was frustrating because at what point are these kids just being kids?
Mm-hmm.
And at what point are these kids, having chemical imbalances? But with all of that being said, um, with insurance, so you are expected to diagnose at intake. And that is such a huge weight on the shoulders of a therapist because intake, you are first meeting this client. And we don't know whether the client is being completely forthcoming with everything that's going on. We don't know our clients, we just don't have the rapport with them. We don't know them well. And so a lot of times you will see a therapist use I don't know what the right term is, but they'll use a lighter diagnosis such as adjustment disorder or
Mm-hmm.
anxiety disorder to be able to bill insurance as they get to know their client because it can be changed. And yeah, it's just it's kind of a catch-22.
Truly, it is. And that is one thing. And I think that's maybe where some of my frustration comes is because maybe this client really does have a diagnosis. I don't have the information in one
Mhm.
hour, 153-minute
Right.
hour to diagnose a client with something more quote unquote serious because I
Hmm.
wouldn't have that information. So I think that's part of the reason why it's easy to say they have generalized anxiety, they have
Yeah.
depression, or an adjustment disorder with anxiety features or whatever.
Yeah.
All the coding. And yeah, that first session, you just don't have the information. I think there's a lot of diagnosis that actually requires testing that if somebody has diagnosed you and you haven't they didn't actually test, that's something that I could struggle with a little bit.
Hmm. Yeah.
Um I also just think there's so much access to information these days through social media. There's a lot of misinformation on diagnosis that kind of like you were saying, we have come to a spot in society where people are much more open-minded about mental health. And I love that we are there. However, I think that a lot of times we tend to swing from opposite sides of the pendulum as a society.
Right.
So we went from there's no acceptance and there's a ton of stigma to now everybody and their mother has a mental health diagnosis and people on TikTok are diagnosing other people. And
Right.
that's a dangerous place to be too, in my opinion. Both sides are dangerous. We got to find a middle ground here. You find a lot of times that at least I've had a few clients that want a diagnosis, and I think that that's something interesting to dig into with a client of why is it important for you to
Right.
have a diagnosis? In my experience, it's because that client wants to feel like they have a community they can connect with. They want
Yes.
to feel connection, they want to feel
Hmm.
known. Um I don't think I think diagnosis for them seems like the easiest way to get there. So to me, it makes sense. But
Yeah.
a lot of times I don't. feel comfortable telling a client, well, I think you have this, because
Right.
I'm also not a medical doctor. Like, I
Hmm.
can't technically officially diagnose. I definitely can't prescribe medication. So,
Yeah.
um, yeah, I think that the reason why clients want diagnosis is typically along those lines of they just want to be able to
Right.
find people they relate to.
Yes.
Like you said though, as a society, there is a lot of misinformation about diagnosis, and you had mentioned depression, like only one of the things is that you have to be feeling it for 2+ weeks or be in a
Right.
depressive state. For anxiety,
Right.
I'm looking right now, the criterion A is excessive worry and anxiety occurring more days than not for at least 6 months
Yeah.
about a number of events or activities.
Right.
So someone might begin to feel anxious about, well, and that's not even to say, I have so many thoughts about this, because there's also anxiety is a natural feeling that we were meant to
Yes.
experience as humans. Like, let's
Hmm.
say you have a job interview. Your anxiety is causing you to prepare for the job interview.
Yes. Planning a
So,
wedding or having a baby.
exactly. There's a
It's going to
healthy
be
amount,
longer than 6 months of feeling this way.
right? There's a healthy amount of anxiety that pushes you to do things that are productive in your life. There is also an unhealthy amount of anxiety,
Yes.
um, which, all of that. So that's only one of the things, and that's at least 6 months. So,
Yeah.
yeah, knowing that if maybe you feel anxiety about a season, that doesn't necessarily mean you have to have a diagnosis for the rest of your life, or that there's a chemical imbalance, because that's
Right.
one of the big things. Like, medication
Hmm.
is to help fix chemical imbalances. Well, not everyone who has anxiety has a chemical imbalance. Some people might, and medication's great for those people. Hopefully, they can find one that
Hmm.
works. But some people don't. And yeah, I don't know. I think that it's just there's so many layers, in my opinion, to diagnosis.
Yeah. I agree. And diagnosis is something that, like, I didn't experience in both internship and practicum. I didn't have to diagnose. I was working at the college and they didn't do diagnosis. And so I kind of skirted around that whole part of it. And I know you did, um, at the private practice that you were at. You did have experience doing it. And so I come into this now, starting a career. I feel like I'm still learning about diagnosis. I also come from a very holistic wellness perspective of, there are times where diagnosis can stand in the way of wellness. And
Mm,
there are times where diagnosis is necessary for wellness. And so it is a very much six of one, half dozen of another, where you're learning to walk this tightrope of what is going to be helpful for my client. If I
hmm
sit here and tell them a diagnosis, how is that therapeutic? And where in this therapeutic, where is that going to meet our goals? And how is that going to help? And so when it comes down to it, it's all about, again, your client and how is this helping your client. And so if you can answer the question of how is this going to be of therapeutic significance for my client, if you can answer that and find that it is helpful, then okay, absolutely share that with your client. If you
hmm
think that this is going to stand in the way of them reaching their wellness goals, then maybe hold back.
Yeah.
Like you said, our clients have access to their notes. So if they want to know and they say, let me see my notes, you have to let them see their notes and you have to tell them. But
Yeah.
you can always preface that with, here is what I think about this diagnosis and you seeing it. Why don't you tell me why you need to see it and how you think it's going to help you before we do this? And you kind
hmm
of walk that with them. And if you can come to a place of agreement, then great. If you can't and they still want to see it, then you've done everything you can do.
Yeah. And
So go ahead.
I think even with clients that I've had or that I've observed during my internship, um, a lot of times the counselor will ask, like, well, what do you think about the diagnosis, to the client?
Hmm.
And there's been some clients that are like, yeah, I was diagnosed with bipolar disorder at, 11. And it does come up that they were experiencing other traumas during that time in their life.
Mm-hmm.
And now they're an adult thinking that they have bipolar, but I've been working with them for over a year and they've never had a manic episode.
Yeah.
And maybe they haven't even had a depressive episode. So now they're carrying around this diagnosis from childhood that has caused them to doubt themselves and
Yeah.
been more detrimental to them than helpful. And
Yeah.
in some cases, diagnosis can be helpful. Like you said, you have to, as a clinician, try to determine if a client's diagnosis will be helpful or will be disruptive to their growth and their well-being. And that can be
Right.
a hard place to be, because for some it can be helpful and it can be like, oh, now I understand why I'm wired the way that I'm wired.
Yes.
Why things,
Yes.
like looking back, there's been some clients, even I think one diagnosis in adulthood would be, I think it's overdiagnosed in childhood, but in adulthood, if an adult finds out and tests and finds out they have ADHD, I have seen a lot of adults find that that actually is helpful for them to know, because they're like, oh,
Mm-hmm.
this is why I struggled growing up and it was so overlooked and I never knew, and now I know why I'm wired the way that I am.
Yeah.
ADHD, I think, can be overdiagnosed in kids because sometimes I think we're diagnosing in children the regular childhood
Their
experience
behaviors. Yes.
and behaviors, but in adulthood it looks ADHD can present differently
Yeah.
too.
Yeah.
So there's just, yeah, there's a lot to diagnosing. And as counselors, for the most part, most counselors are more holistic
Mm-hmm.
in how they view people and their clients. So, but maybe not. Some might really like diagnosing. I
Yeah.
don't know.
Yeah. Well, and from a holistic point of view, I mean, you're looking at the whole wellness. So that we're looking not just at your mental well-being, we're looking at your physical, your emotional, your spiritual. And if you're coming in and you're telling me, I feel really sad and unmotivated, and you're starting to tick off these boxes of what the criteria might be, one of my first questions is going to be, what's your diet look like? What's your sleep look like? What's your exercise look like? Because a lack of those three main components can also manifest itself in a way of looking anxious or looking depressed. And so we're looking at not just we want to check these boxes, but we want to look at the why and what's
Mm-hmm.
behind it. And if we can go, kind of alter some other parts of your life before we jump to like, no, we're looking at a serious diagnosis here.
Yeah, yeah. And for me, something even with depression, I look at is, what does your social connectedness look like? Because I think that
Yes.
that is so important. Human connection is so important to the human
Oh
experience.
yeah,
And
absolutely.
that's why a lot of times people who are depressed will isolate, and that makes it worse because
Hmm.
we were not meant to be isolated. So I think, yeah, there's just a lot to look at. It doesn't end with diagnosis. That's not the end all be all lock and key to counseling.
Yeah. So kind of filtering back a little bit to, the whole purpose and premise of this podcast. Tell me about your first experience diagnosing in grad school.
Good question. So obviously in grad school I wasn't seeing clients that were taking insurance. So there was a little less pressure on it.
Hmm.
I was just seeing private pay. But you still,
Okay.
in our notes, we had to diagnose.
Okay.
So a lot of times in talking with my supervisor, with other clinicians at the practice, they said that they a lot of times would use adjustment disorder as
Hmm.
the diagnosis, which I found helpful. It can be kind of like a placeholder until you know the client more. Like we said, there's not
Hmm.
enough information in the intake when you're needing to diagnose, in my opinion. So the adjustment disorder can be a helpful placeholder. And maybe that's what you stick with. I don't know. But I would say a lot of times I had clients who were coming in saying, I've already been diagnosed with this. And I would ask who diagnosed them. And if it was a psychiatrist, primary care doctor, psychologist, I would go with that diagnosis. And then later, maybe talk with them about it. That can be changed. But yeah, I would say mostly I, at least in internship, did more adjustment disorders, things like that. I found to
Yeah.
be a little bit less pressure just as I got
Hmm.
to know the client, because I didn't feel like I knew enough about
Yeah.
my clients to say, let me slap this label on them as an
Right.
intern. And yeah, but definitely something to talk about with your supervisor in supervision too,
Yeah.
because they can bring a lot of clarity and guidance to diagnosis as well.
Yeah. That's good. So where I was at, we didn't do diagnosis. So I did diagnosis primarily for case conceptualizations for classes. And then later into internship, I realized that I might be behind in knowledge of diagnosis because I haven't had to do it. And so I started doing some diagnosis on my own with my supervisor of clients just to kind of get some practice in. But I will never forget, one of my more, I want to say, intimidating moments was I was doing a case conceptualization and internship. And as I was working through the diagnosis of a client, this particular client had a diagnosis of ODD as a child and some other things. And I'm looking through all these diagnoses and I land on um, a personality disorder. And
Mm.
it scared me. I was scared because this was, I mean, the personality disorders are hefty disorders and they're really heavy for clients to carry. And so I
Mhm.
remember with sitting with my supervisor saying, hey, this is a pretty heavy diagnosis, and I know we don't diagnose, but like, what does this look like with a client? And so we went through it together, and she agreed with me that this was probably a an accurate diagnosis. And so we went through the whole what would be the benefit of telling her, and um, we landed on not sharing it with
Mhm.
the client. And funny enough, this same client was also an undergrad taking some counseling classes and came into my next session after that saying, we just talked about this particular diagnosis in class and I think I have it, and going on and on. And it was the same diagnosis. And I was first caught off guard. And I remember feeling my heart racing and feeling really nervous because she brought it up to me. And we went through okay, well, what would that mean? What would it mean for you to know that you had that? And I never
Mhm.
confirmed or denied, but we did go through what would it mean for you? How would it be helpful? Things like that. And it ended up being probably one of the richest interactions that I had with a client because I learned so much and I was watching this client work through it in their mind and what it would mean. And yeah, so all that to say, diagnosing is not as scary as I thought it was going to be.
Mhm. Yeah. And I think, well, with personality disorders, a lot of times you don't really tell your clients when you
Right.
think that they're diagnosed with a personality disorder, just because there is a lot of weight in a personality
Hmm.
disorder. Not that there's not in other disorders, but yeah. And I remember being nervous about working with personality disorders because people be like, "Oh, like I had this borderline client," and you hear all these stories. But I and everyone would say you'll know when a client has a personality disorder. Your
Hmm.
clinical gut will tell you, like, you might not know exactly what it is, but you'll know there's just something in the room happening that you can't
Hmm.
quite put a finger on. And I don't know that I've experienced a client with a personality disorder yet. I've observed sessions during my internship with clients with personality
Hmm.
disorders, and that's true. You can't, there's
Yeah.
something in the room that you can tell.
Yep.
But yeah, I don't see a ton of benefit of telling a client they have a personality disorder, because there's a lot of stigma, and that could be pretty
Yeah.
detrimental
Yeah.
to
I agree with that.
them. But again, that's another, you have to go by your gut and
Hmm.
dig in with the client if they're wanting a diagnosis,
Yeah.
asking them why they want one, what that would mean. I like that question. Well, what would it mean if you did have this diagnosis? all important things to talk about
Yes.
with your clients.
And if that client were to say, it would mean that that's a big indicator that, okay, this might help.
Mhm.
This might be helpful for the client to be like, I'm going to do research and I want to know how I can work with this, or, and if that's your client's motivation, that's much different than, well, then it means that I have this wrong and I'm this and I'm that, and it's all negative connotations on their lives. We don't, yeah, you want to stay away from that.
Mhm. And something that I feel I've run into is, and I think that this is becoming more common as more and more there's more accessibility to information and
Hmm.
misinformation through social media, is clients will come in and they will be diagnosing people in their lives, or they will be wanting you to diagnose people in their lives.
Uh-huh. There's a lot of that. There is.
There's a lot of that. And so if you are in your internship or starting off or just listening as a person, don't do this to your therapist because a ethical therapist should not be diagnosing people that they do not know.
Correct.
So as my client, I believe the perception of your reality.
Yes.
But I am in no place to diagnose your boyfriend, your dad, your mom, your
Right.
uncle. I've never met them. They've never
Yep.
sat in my room. I will not be diagnosing, and I'm not going to affirm that for you because I will affirm your experience and how you've interacted with that person and how they've treated you. Without a
Yeah.
doubt, that's valid. But I'm not going to say, yeah, that person definitely is a narcissist. Because what is that helpful for?
Yeah.
And I don't know that person. That's not fair to that person. That's a big word to be thrown around
Yeah.
about someone I've never met.
And our supervisors at our internship site very much, many times gave the warnings of being very careful about what you say to your clients about other
Mm-hmm.
people, because if you even indicate that you agree with them, they will hold that and they will say, well, my therapist said this. This is
Mm-hmm.
what my therapist said. Even if you're just like, yeah, I could see that. Then you have agreed wholeheartedly and you have diagnosed that client. So you just have to be very careful with, that you're not giving any sort of affirmation to their thoughts or feelings towards other people and how they feel they should be diagnosed.
Yeah. And it's always hard when I see videos because there are people that
Hmm.
will post videos saying, well, my therapist told me that this and this. Well, first of all, I really hope they didn't. And if they did, maybe look into getting a new therapist because that's not appropriate.
Yeah.
Um,
Yeah.
yeah. Or you're taking things out of context, which that could also happen.
Yes.
Like you said, even if you give some slight acknowledgement of like, oh yeah, that, I could see that, they might take that and run. And
Even
that's not necessarily the clinician's fault.
a
But
nonverbal head nod is all they
yeah,
need.
yeah.
You just have to
But
be very careful.
it's makes me a little weary when I see those videos of
Hmm.
like, oh my, or just, I don't know, you see videos of people talking about their relationships with their therapist, and I'm like, this gets into more of the ethical
Yeah.
side of things, but
Yes.
just like, why is your
Yeah.
therapist diagnosed? I don't know that your therapist should be diagnosing someone in your life that they don't
Yeah.
know. I don't know that that's doing much good
There should
for,
be a therapist should be giving a very clear, well, I can't speak to that, is what they should
right.
be saying.
Yeah. And I have said those exact words to clients before
Yeah.
where I, you know, I had a
I'm
client
not my
who
client.
really seemed to want, or be getting at wanting a diagnosis of the person that she was with. And I said, I am not in a place to tell you to diagnose them because I've never met this person before. And that's not
Yeah.
fair to anybody. And honestly, it just isn't going to do the client that much good to be affirmed in
No.
that.
No.
They're
You could
already
say, I'm
looking for
sorry you feel that
affirmation.
way. Yes.
Yeah. They're
I'm
already
sorry
looking
you're
for
dealing with
affirmation
that.
in other places,
100%. 100%.
which is probably why they're bringing it to you in the first place. If they saw
Yeah.
all of these traits on a TikTok video and now they want
Yeah.
you and your professional experience to affirm that now.
Yeah. You just have to be very careful about it. You
For
know,
sure.
you have to be very careful about what you're saying as a therapist. And as somebody in therapy, be very careful about who you're listening to and what you're reading and what you're believing
Mhm.
because, you never know. I know somebody out there that wrote a book about narcissism that has no credentialing to be speaking to narcissism, and they published it on Amazon on their own.
Yeah.
It's very scary. Very scary.
Yes, there's a lot of misinformation out there
Yes.
and people throwing around very big clinical language without
Hmm.
clinical knowledge. And I'm not even saying that I have all the knowledge, but
Right.
definitely that can be dangerous. And like I said, it's almost like swinging to the complete opposite side
Yeah.
of the pendulum where everybody now is looking or needs a label where sometimes there just doesn't need to be. And I don't want this to sound like I'm hating on diagnosis or people that have diagnoses because I'm not at all. I think that like we said, I want to reiterate, there is absolutely a place for diagnosis in our practice for sure. Um, I just think that sometimes there should be some more hesitancy towards how we approach diagnosing.
Hmm. Yeah. There seems to be a lot of forethought.
Mm-hmm.
We need to make sure we're spending time thinking about how it's going to be affecting our clients.
Yes, which is
Because
the
what it
most
boils down
important
to,
part.
yes, it's all about our clients, not about us,
That's
right?
right. Yeah, all about our clients.
So,
It is not about us.
100%.
Well, any other thoughts about diagnosis? I feel like we really got into the nitty-gritty, but I'm trying to
Yeah.
think if we missed
Oh, I'm
anything.
sure we missed stuff. I think you could talk about diagnosis a lot and for a long time, but like always, I want to know what the listeners think, how they feel. Did anything that we said strike a nerve? Do you want to hear more? Let us know. We're here for you. So,
Mm-hmm. Yeah, and as we say, these are opinions. I wouldn't say that this is. I don't. I'm positive that our thoughts on this do not align with every mental health professional, and that's
right.
okay. And there's room for our thoughts to change on this as time goes. We're just,
Isn't supposed to be very wrong in this. We're new too.
yeah, and I think that every person in a helping mental health profession needs to be a lifelong learner because
Yeah.
maybe 10 years down the road, I'll have a completely different opinion on these things. But
Yeah.
that's why lifelong learning is so important and being open to that as well.
Absolutely.
So,
Absolutely.
yeah, it's a big one. And like you said, there's so many different diagnoses that we didn't even talk about or get into depth
We
about that we
haven't even
could.
scratched the surface.
No, and yeah, you won't ever memorize your DSM, I don't think. But you might. I guess if you do, that's really good for you. I don't see
Yes.
myself memorizing it, but it is a very helpful tool to have as well
Yeah.
and very necessary for clinicians. So I'll say that. It's
This should be your
needed.
first
And
book you buy for your office if you don't have one.
yes, it's definitely needed in a lot of ways as well. So,
Yep.
well, I think
Agreed.
that's all we have for you guys today. So, if you liked our podcast or enjoyed this episode, make sure you like and share with a friend, a colleague, a former or a fellow classmate. I don't know what I'm
Your
saying.
mom, your dad,
Yeah, your aunt, your grandma, grandpa, all the people.
whoever. Yep.
Share it with whoever you want. But we hope that you enjoyed it and that you'll keep tuning in and listening. So
Yes.
thanks for
Thank
joining us
you.
today.
See ya.
Thanks for hanging out with us on Couch Conversations Beyond the Textbook. If today's episode resonated with you, be sure to subscribe, leave a review, and share it with someone you think can relate. Keep showing up, keep learning, and remember, the best growth doesn't always come from a textbook. See you next time.